great pleasure to have Carri Chan today. Carri is a faculty at Columbia School of Business, and she's been doing fantastic work in the area of health operations. She was actually quite a bit in news around COVID, and I believe she helped quite the state and the city in New York. Carri, I think you're in the area editor of one of the journals as well. I don't remember which one. But without much further taking out your time, welcome. And I so look forward to hearing from you. So please go ahead.
Great. Thanks, Sanjay. And thanks everyone for being here. Thanks for the opportunity to speak. So today, what I want to do is talk about some of the work related to COVID. And I know that we're kind of all sick of COVID in many, many ways. And so maybe I'll encourage you to also think about this more broadly as work about how we can use machine learning to help guide decision-making, rationing of limited resources in a healthcare setting. I am one of those people that likes interactive talks. So if you have questions, feel free to pop it in the Q&A or in the chat. I'm happy to try to answer them, and Site is going to help me make sure that I don't miss any. I'll also leave time at the end as well. So this is work that I have been doing with Julien Grand-Clement, who's now at HEC Paris. He was a PhD student here at Columbia. Vineet Goyal, who is in the IOR department here at Columbia. And then Elizabeth, Michelle, and Tina are clinicians at the Montefiore Medical Center up in the Bronx, which is one of the hardest hit hospitals in New York City. And I would say, I guess, in the country during that March to April time period, things were very shaky. In fact, so Michelle is the head of critical care there, and we had done some earlier work on related to COVID. And during one of our meetings, she had to leave because they were getting a transfer of lots of patients because one of the hospitals had run out of oxygen. And so this was kind of during that critical time period of March, April 2020. And that's where this work stemmed from. So let me get started. As I mentioned, I want you to think about this as this work in the framework of trying to figure out how to allocate scarce health resources. And certainly the COVID-19 pandemic put this front and center. This is a figure from the New York Times in December of 2020 about how ICU beds were getting scarce. There were concerns about ventilators, which is what we're going to apply this work specifically to. There was concern about dialysis machines. Now I guess it's getting better, but over the last couple of months, it was questions about Paxlovid as the treatment, and really thinking through how does one allocate these scarce resources. And let's give this a hopeful tone, and hopefully the COVID pandemic is slowly waning, and we're going to be moving out of that really critical period. But the truth of the matter is that there are threats of future pandemics, of other variants coming in, of mass casualty events, extreme weather incidents, where we're going to have to worry about how to allocate resources in these types of situations where demand exceeds supply. And so there's a vast literature going back many, many decades on triaging. How do you prioritize patients for these resources? And I want to highlight what's really critical is that these guidelines need to have a number of features. So they need to get trust of the general public that believes that it's allocating these resources in a fair and appropriate manner. but also of the providers that are actually doing the allocation. Without that, there's no way they'll ever follow the guidelines. And so to achieve that, you need transparency. So it's clear what you're actually making these decisions based on, and that there's consistency. So it doesn't look like it's a haphazard decision. So what we were really focusing on in this particular work, it's just going to be kind of the canonical example that we use for the methodology we've developed, is related to ventilator shortages. So there were in the early spring of 2020, so this is March 2020, and this is also March 2020, talking about fears of having ventilator shortages. And so in Italy, there actually were ventilator shortages. So a lot of articles discussing the gut-wrenching decisions that providers were making of who would actually get this ventilator and who would not. So it turns out that in the United States, this did not become a big issue because a number of decisions were made. Elective surgeries were canceled, and so ventilators are often used in surgery, and so they were able to repurpose those ventilators. They were able to procure additional ventilators. States shipped ventilators to New York to help supplement. And so we didn't actually end up seeing that this triage was necessary. But the question is, if it had been, or in future events, whether it's a pandemic, a mass casualty event, how do you make these types of decisions? And so for us, the question was, can we first try to understand by making a model of the decision process? And it is a decision that is continuous in some ways, in the sense that it's happening sequentially. You make a decision for one patient, and if you allocate a resource to them, a ventilator, for instance, you also have the decision, should I keep them on that machine later, or should I remove them? And so you're sequentially making decisions as patients come in, as patient health is evolving, who is going to get access to these life-saving machines. So with that in mind, we developed a methodology to actually learn from data allocation guidelines, with a key component that it needs to be interpretable. Again, thinking through our providers that are in high stress situations that have to make quick decisions, we want to make sure that our guidelines are interpretable, so they can understand what factors are going into this decision, so that to alleviate some of the stress that is already placed upon them. And so we're going to apply this particular methodology to the application of COVID-19 by evaluating existing guidelines. So New York State actually has an official New York State triage policy that if the governor enacts a state of emergency, that this is what the providers would follow. We want to think about how ethics and fairness come into consideration in these types of decisions. And very importantly, this work is through collaborations with the critical care team at Montefiore and clinical ethicists as well, because it's both an efficiency but ethical question when making triage decisions. So I'm not going to be able to, given the time and the vast amount of literature in the space, be comprehensive. I just want to kind of bucket it into the three main areas. So there's been a lot of work on triage in the operations community. We will be using MDPs and machine learning in the healthcare space. And then more broadly, some of this work is in healthcare, some of it is not, in doing interpretable sequential decision making. As we get into the work, I'll go into more detail on this particular paper by Florian and Velibor, which is very closely related to what we are trying to do. right? So let me just give you a roadmap of what I'm going to do in the remaining time. I want to give you a little bit of background on ventilator allocation and specifically New York State's approach. Then I'll present our model and then our approach to how do we train this to get interpretable policies. And then finally return back to that ventilator decision to figure out what to do about it, right? All right, so the first question is, if we think about triage, what is the goal of this? And so the ultimate question is, which patients should receive priority for a life-saving treatment when there are shortages? Within the United States, 26 states have guidelines of how to do these allocations. Not all of them do, clearly. And actually following Hurricane Katrina in New Orleans, New York State decided to create a task force to come up with ventilator triage algorithm. And it was motivated because actually after Katrina, it was documented that providers were making, in providers' word, arbitrary decisions on who would get life-saving care because there wasn't a framework that existed at the time. And so New York State said, you know what, we want to make sure that we avoid that situation. We want something that can have transparency and be interpretable. So this is just the New York State guidelines of how this is going to be happen to make sure that the allocation plan is actually, as you can see, you want to reduce morbidity, mortality, and economic consequences. And so the primary objective, as they were outlined, was to maximize the total number of lives saved.
Are you back on? Yeah, you back on.
Okay, I have no idea what happened.
Yeah.
Apologies. My internet apparently went out. I'm on campus, but I don't know. Apparently Columbia's infrastructure went down for a moment. Where did I lose everyone?
Maybe you want to go back to the previous slide and just continue from there, because
Okay.
I think it was a couple minutes ago. Yeah, right here. So you were talking about these 26 US states.
Okay, and then
with the policies.
Okay, great. So you're all still there, right? Okay.
Yeah, we are there.
Okay. So has these different policies, or this is the policy by New York State. And so the goal of triage algorithms is to, reduce loss of life, to promote fairness in the terms of these allocations, and really to support the frontline clinicians as they're making these decisions. It is a very, very stressful time for the providers, especially when you know that you're making these life-changing decisions. So what does New York State's algorithm actually look like? The objective is to basically maximize the number of lives saved. And the allocation is based on the SOFA score. So I know many in the audience are very well versed in the SOFA score, but for those who aren't, the SOFA score is a measure of organ failure. And so you get a certain number of points for each organ system, cardiac, respiratory, etc. And the higher the number, the SOFA score is predicted with a higher risk of death. So the New York State Triage Guidelines has 3 primary decision epochs. The first is when a patient arrives, and in this case, I think of arrival as arriving to the need for a ventilator. So the provider has determined that this patient would benefit from a ventilator, and then the question is, should we give them the ventilator or should we not? Right, so are we actually going to allocate the ventilator to this patient who needs it? Now, assuming you actually give the ventilator to the patient, there's 2 additional reassessment epochs. So first after 48 hours, and then again after 120 hours that says, should that patient continue to be able to have the ventilator, or should we actually take that patient off the ventilator? And this is in the absence of resource constraints, the patient would stay on the ventilator and the patient would be given the ventilator at time 0. So this is, we know that they need it, but who and when should we actually take it away from if we are resource constrained? So the guidelines are, it's actually, again, to promote transparency. It's actually quite simple. It's summarized in this grid. So this is at time 0, who should get it initially. And so the blue and green categories are excluded. They will not get a ventilator, but for 2 very different reasons. So the green patients aren't getting the ventilator because they're too well. They don't need the ventilator. The blue patients have a very high SOFA score. And so the rationale is that these patients are too sick to benefit. And so they transition to palliative care. Then between the red and yellow, and you can see it's based solely on this SOFA score, depending on its value, you give priority to first the red patients. If you are able to allocate ventilators to all of the red patients and you have additional ventilators, then you can allocate to the yellow patients. So it's actually you can rewrite this in terms of the SOFA score, and it's, increasing the SOFA score at the extremes, you don't get priority, but in the middle, it's this, actually the higher priority is they are no longer too well too well, they're sick, but they're actually not too sick. So we're going to give priority to those that are kind of on the cusp of where this ventilator is going to have a lot of benefit. The overall categories at reassessment are similar. The difference is that it determines on whether or not the patient is improving. So it's still cutoffs based on the SOFA, but it then says if you get higher priority if you're actually improving while on the ventilator. So if your SOFA score is decreasing, you're getting better, and so you get to continue having it. If you're actually not improving or you're getting worse, that actually puts you, you're on the exclusion criteria, and you may actually have the ventilator removed from you. Now, in talking with the providers, I think all of these types of triage decisions are very challenging to make, and it weighs heavily on them. The reassessment and the decision to actually take away a ventilator, they said, is much, much more challenging than the initial decision of should I give it to them or not. Because once they're already on it, you know that if they stay on it, there's a chance that things maybe get better, but you're actually taking something away from someone rather than not giving it to them in the first place. And psychologically, they said that this is a very different decision that they need to make. So just a couple of things that I want you to note from the New York State guidelines. The decision making is dynamic, so there's 3 different decision epochs. It's very simple to understand and to implement. You're making these decisions very rapidly in these high stress situations, and so both of those are necessary. It's also not tailored to a specific disease progression, so it's based solely on the SOFA, and there didn't exist a COVID-19 virus when they were developed. And so the question is, like, maybe you need to actually change depending on the evolution of the disease state. Especially for COVID patients, we saw early on that some of them were staying for very, very long periods of time. And so that's not incorporated in these decisions. And then finally, they made this decision with a group of providers coming together and ethicists, but it wasn't based on data. And so it's unclear actually what the performance would be if this algorithm had to be used. So that brings us to what our key questions are in this particular work. Can we do better than the New York State guideline. So first and foremost, one can think of, in the absence of triage guidelines, first come, first serve is kind of the simplest policy. If there's a ventilator available, you give it to the patient. If there's none available, you don't. It's kind of the fairest decision. And so the first question is, does New York's this current recommendations do better than that? And then the question is, can we actually come up with an interpretable policy that does better than the New York State guidelines? And if so, New York State is based solely on SOFA. So are there other information that we want to incorporate to make this particular decision? All right. So let me get to the model. And so here are just fictitious patients whose health state is evolving over time. It's going to evolve stochastically over time. And we're going to look at a finite horizon where there's a terminal state. So we want to see, once the patient needs a ventilator, we're going to follow them until they no longer need a ventilator, either because they die or because they've recovered and they're alive. We have a discrete set of possible actions. And so this is, in the case of the ventilator allocation, is basically, do I allocate a ventilator or not? But even in respiratory disease, you could think of, do I give them a ventilator? Do I give them oxygen therapy? You could think of a menu of different actions. And the particular action that is taken will dictate the evolution to the next state. So the state transition depends on the current state, the action you take, and then where you're going to land. Now, in this particular model, we are going to be modeling the single patient trajectory. All right, so we're looking at a single patient. We're making decisions. Do I allocate for that patient? Do I not allocate them? And this is in part because trying to optimize the entire system, it becomes very intractable very quickly. Your state space is going to explode if we have multiple different states of the patients. With SOFA, they already have over 10 different states they could take. If you take in other demographic information, comorbidities, your state space grows very large and becomes unwieldy. And so what we do is we incur a cost for each action, depending on the state and action that you take, where this is going to reflect the costs associated with being in a patient being in a health state, as well as the capacity constraint. So intuitively, we expect this cost to be non-decreasing in the amount of resources that are used. The more resources you use, the more costly it's going to be. And that's how we can try to capture this capacity constraint. One thing that I should just be very, very upfront about is, in this particular model, we don't consider returns to the system. So some patients, they are given a ventilator, they come off it, and they may actually come back. We wanted to first look at that initial phase, and also just in terms of a practical standpoint, there's not enough data in our data points to really learn what to do for these readmitted patients. So our objective is, perhaps you knew this was coming, was to essentially find our policy that minimizes the cost incurred over this finite horizon. So we want to make these action decisions. Do we allocate? Do we not allocate at different decision epochs in order to minimize our overall cost? Where again, those costs capture the resources we're using and the health state of the patient. All right, so in trying to find that policy, I keep harping on this, the key component is to make sure that we have interpretability. There is a lot of excitement in the healthcare community broadly on using machine learning, AI in healthcare. I would say in some areas, penetration has been pretty good. In actual delivery, it has been more limited because many of these models are black boxes. And so if you're creating a decision support tool for providers and they have no idea where the recommendation is coming from, there's a high degree of skepticism that a machine is able to do as well as what their clinical expertise is able to. And so the question has always been, like, are there ways to make these types of decision support systems more interpretable to help facilitate use? This also allows that providers, if they disagree with the decision, they can know why, and they can make the decision to deviate from the recommendation, but they understand what are the factors that come into play. And so it's really important to try to achieve interpretability in order to actually get operationalized decisions. So there's a lot of different ways one can think of interpretability. Sparsity is one way, so having limited number of features, using linear models so it's clear how each feature contributes to the particular decision, index-based rules, so you get strict priority, and then there's decision trees. And so we are going to be focusing on decision trees in this particular work. In fact, you can actually make the New York State triage guidelines, you can change it into a tree policy. So essentially you're branching on the SOFA score. Is SOFA very high? Then that patient's going to get low priority. If it's moderate or low, then you are going to branch appropriately. You can also split the reassessment guidelines into these trees. So what we want is to think about this notion of interpretable sequential decision making. So again, we have multiple decision epochs, and decision trees are not new in healthcare. Lots of people have done it. They're actually, it's an example of where there's been good penetration of machine learning in healthcare. They're often single decision points, right? But what we want to do is make decisions over time. As the patient's health is evolving, we also want to continuously have interpretations. And so what we're going to be thinking about is this notion of interpretable sequential decision making. So in each time point, we actually will have a decision tree that is going to recommend what the decision should actually be. And so you have a sequence of decision trees. So Florian and Velibor have a management science paper that also look at interpretable sequential decision making, where they have decision trees that change over time, but they're focused specifically on stopping times. And so once you make that decision, the evolution is going to stop. So you're making a decision, and every time epoch, do I want to continue or do I want to stop? So that's what they've done. And what we're doing is we're looking at a finite horizon. So if you make a decision to act, you keep going, and you can make a decision. You have to make a decision whether to act or not act in the future. We also, even though in the ventilator application, we have a binary decision, yes, no, the methodology is for a menu of decisions. So we can look beyond a yes, no decision. So it turns out, perhaps not surprisingly, that finding the optimal sequence of trees for this sequential decision problem is NP hard. And it's fairly straightforward to show this, because you can essentially reduce down to saying, I have a single period decision. And even then, we know finding optimal trees is hard, right? So one can consider a heuristic approach. This seems like a reasonable approach. Let's first find the optimal unconstrained policy. So let's solve the dynamic program, find what the optimal policy is, and then we'll fit a tree to that policy. And so each decision epoch, we're going to fit a different tree to that. And so it seems like a reasonable approach, but because we know fitting the tree has its own challenges, it can actually perform quite poorly. And it also has the drawback that when you're fitting the tree, it doesn't think about the fact that there's something happening in the future. Those dynamics of your decision should be taken into account, that your dynamic program is actually able to handle. So the methodology that we propose is to actually optimize sequences of trees. So we're going to adapt the dynamic programming algorithm to do a recursion where we're optimizing each tree and each decision epoch. So we're going to first start at the terminal state, and we're going to fit the optimal tree here. Once we have that optimal tree, we can go back one period and we can readjust our costs for associated with each decision, where the costs are the current single period rewards, as well as the future rewards, knowing that we're using our fitted tree in the future. And so we have to modify our cost, and then we fit the best tree to the current decision epoch. Now, in this particular case, we're going to use off-the-shelf tree algorithms like CART to actually fit that particular tree and find what that evolution is going to be, right? Take a pause for a moment and see if there are any questions. All right. All right, so let's return to the COVID-19 ventilator allocation decision. So I want to use this model and this algorithm that we've decided to develop a sequence of decision trees to compute these interpretable guidelines for ventilator allocation. So we're going to start by utilizing the framework that the New York State system has in place. Kazim, yes, the original decision is happening at time 0. So it's happening at time 0, but it's I guess we can keep going back to t equals 0 for that initial decision epoch. So you can think of the time slot t equals 1 as where we're starting, but it corresponds to the 0th hour. Right? All right, so there's a question to explain the overall approach one more time. So let me see if I can do it this way. All right. So what we're going to do is at the terminal state, we are going to fit the optimal tree given the terminal costs. Okay. Then when we're going to go one time step back, and we have for each action, we have the associated cost of the state and action, right? We are going to now modify the cost to be the single period cost plus the future costs, where our future costs are dictated by the decision tree we're going to use in the next time step. So we have this modified cost for each action in the current time step that we are using, and we fit a tree to that particular decision epoch. And so then you keep recursing like a dynamic programming algorithm where we're modifying the cost to be the future costs, but we're restricting the policy space to be within the space of trees. And so we keep going back and keep recursing. Kazim is asking if the tree structure changes over time, and we've depicted it as it can. So we allow it to change over each time slot. And then when we get to the numeric examples with COVID, you'll see what actually ends up happening. Right. So Citron, who is asking, what is the main benefit of using a decision tree instead of a more traditional approach? I think that's a great question. So one could just use the traditional dynamic programming algorithm and then you have the optimal policy. The challenge with that is that you can create a table for what the decision is going to be, but it's very difficult to convey the decision process and the factors that go into that decision to the providers. And ultimately, the providers are the ones who are going to make the decision. And in these high stress situations, you want it to be clear and simple to implement. So in that regard, decision trees are something that providers are aware of and used to in many ways. And so this can help facilitate use of these types of guidelines. All right. So let me get to the ventilator allocation decision. And I'm going to be using the decision epochs that exist in the New York State algorithm. So at 0 hour, after 48 hours, and after 120 hours, right? So in this particular case, essentially you can think of our horizon, because we have 3 decision epochs, as that you have 3, your horizon is of 3. We're making that decision at 3 different time periods. So the data that we use is all of the COVID-19 patients hospitalized at Montefiore Medical Center between March and June of 2020. So there was 807 of those patients, of which 543 died. So you can see very, very high mortality rate. And then we have some static information about the patients, their age, their gender, their BMI. Charlson score is a measure of comorbidities, and then these specific comorbidities that they have. So that doesn't change while they're in the hospital. Every 2 hours, we see how their SOFA score is getting updated. And so again, this is a measure of organ failure. And then finally, we know how many maximum number of ventilators used at the same time. This is actually a fairly remarkable number, because they estimated pre-pandemic for kind of standard ventilator use in the ICU across their hospitals, there was 180 ventilators, and they were able to flex up to 253 by procuring more, by borrowing, and by canceling surgeries. So this is why they actually never ended up running out of ventilators and having to make these triage decisions. But you can imagine that if New York hadn't been hit so much earlier than the rest of the country, this might not have been possible. So Abanov is asking if you can use a regular decision tree approach to make this decision. And so yes, we actually use you can use any off-the-shelf tree algorithm that'll learn a tree. You just have to, the methodology is really about making sure you appropriately adapt the cost functions and do it. You learn the trees recursively to incorporate those dynamics. So I'm going to start by presenting the policy that is learned from the data that focuses only on using the SOFA score. So this is the only criteria that is used in the New York State guidelines. And so let's see what might happen there. The benefit, again, is it's very simple. There's only one piece of information that you need to gather. And in these high stress situations, that is helpful. So what do we find? First, it's actually more simple than the New York State guidelines. So at Triage, there's essentially a cutoff of the SOFA of 11, whether or not you're allocated the ventilator. And at reassessment, you see that it depends on this SOFA score only. And so in some ways, you can think of the policy that we learned from the data as being less aggressive than the New York State guidelines for extubation, for withdrawing ventilators, because actually New York State's guidelines will remove patients whose SOFA score are greater than 7. So you could have someone with a SOFA score of 8 who would be removed if they are not improving. So it's actually, if they don't see improvement in the patients, they're going to actually take them off. And this is something that for COVID is really important, because we saw once data started coming out, once patients got on ventilators, they actually ended up staying for a very, very long time. And so it took a while for their body to start to recover. And so the New York State algorithm that was designed without knowing anything about COVID, without the existence of COVID, missed that disease-specific progression that our algorithm was able to capture. So we wanted to then think about, if we utilized this algorithm, or as I said, they never ran out of ventilators, but what if they weren't able to triage and procure more? What would the impact have been? And so we want to then compare, as this evolution over time, the survival under the official New York State guidelines, under first come, first serve, which I said is kind of the most fair in many ways. You're not actually triaging, it's just based randomly on when people arrive, and then our proposed tree policy. So to evaluate this, we are going to use simulation, and we are going to vary the patients arriving. We're going to sample with replacement patient arrivals and their ventilator demands and how they're evolving over time. In the absence of a capacity constraint, ventilators are allocated on a first come, first serve basis. So that is what we are going to follow. You don't actually start triaging until you run out of capacity. So ventilators are going to be allocated on a first come, first serve basis. If capacity is reached, then we're going to allocate depending on the triage policy. So these 3 policies that I mentioned. If a patient is given a ventilator, we're going to reevaluate at 48 hours and 120 hours, as the New York State algorithm does. An important component to this model is to think about what happens if patients are not given a ventilator, so they weren't allocated one when they needed it, or they were given a ventilator, but then they were extubated early. And so we're going to assume that they die with some probability P if that happens. Now, the good news, bad news is, the good news is that this never happened. The bad news means from a statistical standpoint, there's no way for us to actually know what the impact would be of extubation or withdrawing ventilators. You certainly can't run a randomized trial. And so let's think about what this parameter P captures. If it's close to 1, it means that anybody who is extubated basically won't survive. Extubation is going to kill someone. If it equals 0, it means that actually extubating a patient early doesn't have any impact. And intuitively, in our provider, I think for those of us who are not clinically inclined, but also for our provider clinical collaborators, P should be quite large, right? Somebody who needs help breathing and you're taking away that help, there's a very high risk of death when that happens. And so we looked at different values of this parameter. So just to make things concrete, I'm going to look at P being very high, 0.99, and here's my comparison. So first, the New York State algorithm is here in blue. And so on the x-axis, I'm varying the total ventilator capacity. On the y-axis is the total number of deaths. So we're starting from, this is what we actually observed in the data. They were able to get 250 ventilators. And then this is actually what would have happened if they weren't able to procure any. The total number of deaths there would have been. So you can see there's increase of over 30 deaths as a consequence. Now, at least to us, this was very surprising. In red is first come, first serve. So you can see that the New York State guidelines don't actually improve much over first come, first serve. Now, the differences are actually statistically significant, but they are not economically or ethically significant in the sense that it is like a tenth of a person in terms of the differences, which is, I think, pretty remarkable that you have this guideline, but it doesn't do much better than having no guidelines whatsoever. In green is the optimal MDP policy using just the SOFA score. So you can see you can do better. As I mentioned earlier, the challenge with this is it's not very interpretable. So if we look here, this blue dotted line is our tree policy using just the SOFA score. And so you can see it improves by actually saving about 20% of deaths relative to New York State and first come, first serve. It's not the optimal policy. And so we know that it's not going to be able to match the MDP, but it's much closer. And so we're able to save lives while still having an interpretability to hopefully facilitate use. You can see here, actually, maybe I'll first highlight it here. Interestingly, the tree policy that uses SOFA score and age, so this is learned using both SOFA and age, actually ends up with more deaths, which at first may be a bit of a head scratcher. So let me just delve in a little bit what's happening here. So this is the tree policy that is learned at time equals 0. And so it partitions based on age, so elderly versus not, and then severity. So a couple of notes. One, these tree policies are not guaranteed to be optimal. So even in the single stage decision, they're not guaranteed to be optimal. And so when you have sequential decisions, it also is not guaranteed to be optimal. Age, on top of the SOFA score may not actually be a great predictor of death. And so that because the SOFA score is capturing more about what's happening acutely in the patient. On top of that, our clinical ethicist collaborator raised concerns that using demographic criteria could raise, pretty substantial concerns from a fairness standpoint. If you're saying that, you're excluding certain age groups, or you're excluding patients with certain comorbidities, especially because of the way the US healthcare system has been set up, many people with certain comorbidities, they disproportionately affect underserved communities. And so it would be further increasing health disparities. And so in many ways, they found the policy based on SOFA only to be more desirable, and also with the benefit that it has better outcomes. So I see Kazim has a question about using other covariates. And so we actually also, it's hard to see it, the yellow, beige dotted line is the SOFA score plus some of these other covariates. And so when you add more covariates, they seem to have similar performance, but it's obviously it's more complicated as well, which makes it more challenging to implement. I'm going to just skip over that. With other values of P, you get a similar performance qualitatively. So I guess I want to wrap up so there's a bit of time for questions. What we saw from these simulation is that surprisingly, New York State guidelines did not appear to outperform first come, first serve. I think this highlights the need that when these disaster pandemic scenarios arise, because pathogens impact the human body very differently, it's important to try to get data. Even small amounts of data can hopefully provide better performing guidelines than ones that are made in a vacuum without targeting towards the evolution of that particular disease. Our tree policy that we learned can reduce the number of deaths by 20 to 25%, depending on how much ventilator capacity there is. And there could be some benefit for adding demographic and comorbidity information, but it's not necessarily going to like vastly improve. And so excluding that information has the two benefits of it doesn't increase complexity. So including them makes it much more the policy more complicated. And two, you kind of avoid some of these ethical landmines that may arise depending on how you're allocating based on this demographic information.
So I know we have only 5 minutes left. Carri, are you done or you just?
I am done. So my final
No.
words, just to have what we've done here is to create a model to make these sequential decisions. The guidelines from the experts are important. And so we trained it with using kind of that framework of that time period, but we can fine tune when you have data and this methodology. I think there's some interesting questions for future work. Should we change the timing of reassessment? And should we have guidelines that actually adapt based on capacity or ICU capacity? Because you often need to have patients in ICUs when they're on ventilators. So with that, thank you very much. And I see there are questions, so I'm happy to take them as well. I don't know, so do you want me to pick and choose or you want to pick and choose?
Well, I think we have a bunch of questions from 3 different individuals. I may be missing one, anonymous. So we can give everybody like all 3 to kind of to like a single chance, given we only have got 4 minutes left. So now you can pick and choose.
All right, I'll pick and choose. So Jacob says, could I evaluate the 26 different states with their own guidelines in terms of lives saved? Yes, we could, and we could do it off the New York State data. So the 26 different guidelines are not all ventilator allocation guidelines. They are resource triage guidelines. And so they're not necessarily specific to ventilators, which makes it challenging. We didn't go through and evaluate every single one of them, in large part because our collaborators are in New York, and the question was, should they be following the New York State guideline? How robust is the proposed method against the potential change in the cohort, different disease prevalence or variants? Does it need to be re-optimized? So yes, absolutely, it would need to be re-optimized. I mean, that I think is one of the big takeaways, as you can see, that gap between the New York State algorithm and what we have here. It demonstrates that as things, you want to tailor it to the disease progression that is there. What if I compare strategies before COVID data? So we don't have, so for patients respiratory, we'd have to look at respiratory data pre-COVID. We didn't have that data, but you could certainly look at it and is an interesting recommendation, and perhaps looking at other disaster scenarios like the Katrinas of the world, we could evaluate what would happen there. Is the backward tree fritting procedure exact, or would be possible to find a different optimal sequence of trees? So you could possibly find different sequence of trees in a different methodology. Because finding the optimal tree for a single decision epoch is hard, I think with the sequence, you're not going to be able to find a computationally efficient methodology to do it. And so then the question is, like, could you come up with heuristics that could do better? Probably. This is our first approach that we could try to evaluate and make sense of, but there's likely others that could do better. How easy is it to generalize this to daily assessments? Very easy. So instead of doing the 0, 48, and 120, you absolutely could do it. I think that creates an undue burden on the providers if you have too frequent reassessment. And so the question is, I think for me, the natural next question is, how do you optimize those reassessment periods? And can we do that within this particular framework as well? I am going to, I think, have like 30 seconds to answer one more question if you'll afford it to me. I guess the easy question is Doug He, which is, does the algorithm consider the workforce, the number of nurses or doctors? It does not right now. So the computational time is for the tree methods it's similar. It depends on what algorithm you are using to learn the tree. Essentially, it's linear. It's the number of decision epochs times the runtime of that tree algorithm. And so that's the way to look at it. And so I'm over time. I appreciate the
you can take an extra minute. Answer Pengy's question too.
I don't know. Let me bring it back up. But I welcome feedback over email. So certainly feel free to reach out to me that way. Pengy, I don't know where your other question is.
Well, it's the same. Thanks, Carri, for the great talk. 2 questions. What's the computational time for tree-based methods compared to conventional MDP? And second question is, does this method relate to Monte-Carlo tree search methods in reinforcement learning?
So I think the different, this is we're doing this offline, right? So we're taking the data and then we're training it rather than trying to gather data and adapting the policy as well. I actually think in this particular setting, doing something like a reinforcement learning would be very challenging, because if you're telling the providers every day your policy is going to change, that is going to be incredibly problematic. But if you said, here's the methodology, now we've gathered, 100 additional patients and we're going to retrain it from that data, and here's now what the algorithm is based on what we've learned, that's much more likely to facilitate implementation. So thank you so much, everyone.
Well, we want to thank you. We want to thank you. I know we're a little bit over time, but you did quite finish and answer all the questions. Wonderful talk, and I guess virtual claps here. Thank you so much.
And apologies for the technical difficulties.
You made up for that.
All right. Thank you, everyone. Take care.
You too.
Bye. Have a great talk, Carri. Bye.